have an introductory slide for him. Dr. Carlo is his talk is on evolution of coronary implants. What do experts say, and where are we heading into 2020? He's from Italy, and he has multiple achievements. He's fellow of Italian Cardiology Society. He's full member of Euro CTO Club, an adjunct professor of cardiology, and instructor also for ACLS and AHA. He has multiple publications in his city. So I will invite Dr. Carlo for the next talk.
Thank you for your kind invitation. Very happy to be among colleagues, esteemed colleagues. I will share my presentation right now. Okay, and I'm starting talking about the evolution of coronary implants right now. Where are we heading in 2020? Obviously, when we talk about ischemic cardiomyopathy, we have to talk about a planet that has two phases. And obviously, these two phases are completely different one to the other one. Like the stable ischemic heart disease is different from the acute coronary syndrome. And so I would like to start talking about the stable ischemic heart disease. And here the question that I could ask myself is if there is still a role for PCI, considering the trials that came out in the last years. They were very skeptic about the revascularization with PCI. The first was Courage, obviously, but then became Orbita and ischemia trial after a while, just talking some tough messages, like the Courage trial, the theory was the optimal medical therapy as the same depth MI as the PCI. In the Orbita trial, that were no benefit in symptoms, considering the PCI for treating symptoms, and obviously that there was no events benefit in the ischemia trial. But I think we should focus which one, which study has, which is the result, because if they are being so poor, there should be a reason. And I think the first reason is that the PCI is an inherent risk of complication. If we see the ischemia trial, Kaplan-Meier curve, you can see that in the beginning, we have to pay this kind of price of the procedure, and it's obvious because obviously in optimal medical therapy, we don't have this risk in this phase. But we have to consider that we should gain something in the lately period, like in the preceding months and years. And if you see here, this benefit is clearly visible also in ischemia trial. But of course, in a population like the ischemia trial population, I think the risk was not so high, so I think we should take many years more to give this benefit profitable compared to the optimal medical therapy. The other point is that PCI without this effective ischemia reduction is useless, and as we know, there are many procedures just done by the visual estimation of the stenosis. For example, in Orbita trial, up to 30% of the patients were treated for visual estimation of the stenosis, and the lesions were physiologically negative. And this is something we have to face in the real world practice, but we should fight with this point because we need to reduce the ischemia in the lesion treated. And the other point is that we should give good early and long-term results because for example, in the Courage trial, the deaths were used just in a few patients, and there was a high percentage of patients who crossed the line from optical medical therapy to PCI. The new in the line, we have new studies that shows that the benefits are completely linked to the PCI. We are not doing something unusual. And the first point is that we can highlight the angina reduction is clear in every study. We can show also the study that I mentioned before. There's a clear benefit in the PCI in angina reduction compared to an optimal medical therapy. And it is clear also in the ischemia trial. But something that probably shocked the population of the interventional cardiologists, because we're all talking about angina and sometimes other benefits, but not MI reduction. But in this 5 years follow-up of the FAME2, so all patients were treated with significant lesions assessed with FFR. after 5 years, as you can see, there is a reduction also in spontaneous myocardial infarction. I could explain this point considering that critical stenosis, they're not always benign, so they can give angina, but in the preceding years, they could give also MI, and if you treat them, we can reduce these risks. And obviously, we'll talk about benefit on survival. It's not always the same, so we should focus on the extent of CAD in the patient, because obviously, if you have one vessel disease, it's really difficult to have a benefit on survival. Probably you should live something like 200 years. But if you have a 3-vessel disease with proximal LAD, compromises more than about 90% stenosis, then you have a 5-year survival rate that's much lower than in the general population. And this is clearly also seen also in this trial, nice trial that was assessing more than 50,000 patients from with a known CAD undergoing CTA, so it's a modern study. And we can see that if they were revascularized, we can have a benefit just if the patient has a 2-vessel or 3-vessel disease. Considering stable ischemic heart disease, my personal view, it's an analysis of different points. I think we should focus on symptoms when the disease of the heart disease is not so involving the 3 vessels, so 1 or 2-vessel disease. We should focus on symptoms. So the patients who are asymptomatic, I think you should also think about optical medical therapy alone. But anyway, if we want to treat a lesion, we should always assess if the ischemia is confirmed, more than all in patients with stenosis from 50 to 75%. But if you have a left main disease or proximal LAD disease or a 3-vessel disease, revascularization gives a clear survival benefit. Then we can shift over the ACS, and we know that revascularization is something like a light in dark in the ACS. We cannot debate on the benefit of revascularization in ACS, but we could talk about modern cornerstones in this revascularization. For example, we should be fast, we should go by radial, we should use DAS across all spectrum of patients, we should try to achieve a complete revascularization. Talking about each point, I think early revascularization has proved an effective benefit over the delayed revascularization. This is a meta-analysis of 7 randomized trial, 80,000 patients. We saw not just a reduction in MI and recurrent and stable angina, but also better survival. And this is why, with even more studies came out in the last years, that 2015 guidelines from European cardiology just divided the access for ACS in a fast access in less than 24 hours in patients with sometimes dynamic, presumably STT segment changes and troponin positive, but we can focus also in patient who has less than 2 hours access in the cath lab if they have some high-risk feature as shown here. Another cornerstone is the radial PCI, because we can see from the biggest trial in this field is the Matrix trial that we just started in Italy in our center in Ferrara just a couple of years ago. And we can see that the benefit in radial percutaneous coronary intervention is clear. The trial was assessing not just ST elevation MI, but also ACS in general. Obviously, the benefit should, it's more highlighted in the ST elevation MI, and this is clear also for other studies. But as you can see from Matrix, the results are good also for ST elevation MI, non-ST elevation MI. This is why also not just in acute coronary syndrome, but also stable patient radial access gain the standard approach label in the European Society guidelines of 2020. Another point is that the DS progressively gained indication for all spectrum of patient, and most of all, the patient we face more often, like the patient with high bleeding risk, like the older patient, because the stent in the second generation tried to fix one of the biggest problems was the stent thrombosis and restenosis, because they get thinner, they modified the polymer that was taking the drug with them, the stent coatings, and the surface modification. The first trial that showed that we can use DS with just 1 month of double antiaggregation was the Leaders 3 that was studied also in ACS with good results. But I think that if you have a good stent, then you can achieve this kind of results with any stent. And another thing is that we have to achieve a complete revascularization in a multivascular disease. Obviously, it was studied much more in the ST elevation MI. These are two very big trials that showed that if you PCI all the lesions, you have far better results than to treat just the culprit lesion only. Obviously, in ST elevation MI, it is clear. Probably in non-ST elevation MI, the trials are lacking. This is just a register from the English Society showing that you can use a single procedure PCI for all these lesions. So compared to the ST elevation MI, it is better to do it one stage. This is what we see from this trial. And obviously, I want to focus that we are starting right now. We enrolled half of the population we decided to enroll in this FIRE trial with a new generation thin strut stent, the Superflex Cross. And we should assess the patients with older age that were not included in a previous trial. And we'll have answer about this if it is true that complete revascularization works also for older patients, more than 65, 75 years old. But what's going on in 20 years ago? I mean, if we were going in the first procedure, which lesion we were able to try to treat with PCI? You know that devices are completely changed in the last years. This is what we treated mostly when we started performing PCI. But this is what we face right now. Patient with acute septing, much older than in previous period, with serious comorbidities and often ruled out for CABG. So patient that should go to CABG, but the surgeon refused them to operate. How I can obtain complete revascularization nowadays in such a patient with such complexity? Obviously, we should treat the patient with the right strategy and with the right tools, because sometimes it's easier just to treat the focus on the culprit lesion. We need all tools. I'm highlighting that we should have all tools in the cath labs, because you never know which one is the right for the patient. And one of the points I want to highlight that you need complete functional assessment. We have these two systems right now that are very useful in this patient. The Coroventis from Cordis from Abbott is a system that assesses not just the FFR but also EMR and CFR in this patient. This is more and more true when you have patients with less than 0.8, but even more when they have more than 0.8 FFR. So the patient doesn't have ischemia, but you have to explain why there is angina. So we should try to focus on which is the reason why there is angina. For example, as Dr. Kumar pointed out, there is sometimes dysfunction in the microcirculation. But the other point that we can have FFR measurement also without any guide wire down, like in the QFR that we are using, just analyzing the angio images. Another point is that we need imaging, not just because we have to use in all patients, but there are more and more patients with ST elevation MI or non-ST elevation MI where we have doubts about the reason why there was enzymes and chest pain, because sometimes we have lesions we have to assess more deeply. And as you can see from the images, with OCT or IVOS, even IVOS, you can see messages and information that are very useful for your daily practice. Another point that we need the cutting edge technology for your stent, because if you want to treat very complex anatomies, you need stents that should be delivered to the point without any issues. It couldn't be so easy using the first generation stents, so you should look for stents that have a thinner strut and deliverability, and most of all, open cell design, just to be able to make curves, and best for bifurcation, so to access the side branches. And another point is that you need a stent that could just behave very well also in the clinical endpoints, because you need a biodegradable polymers that should be probably the best in patients with high bleeding risk. Another thing I want to point out that you have to face with patients with a lot of calcium in the coronaries. So you need a atherectomy, you need rota system, IVL for sometimes. And I want to include in this list also the ELCA, the laser system, because I think there are patients who could benefit also with this technology. As I can see from this example of a patient with 3 vessel disease, that you can see diffuse calcification in all the vessels, tortuosity, and tortuosity also in the vasculature of the arm. We decided to treat this patient in a CTO fashion with a cyan guide wire, just trying to go down to reach the distal end. As you can see, there is a lot of calcium, and the micro catheter was really down, was not able to go down along with the guide wire more than the proximal segment of the LAD. So we decided to advance the laser cut, 0.9 cut from Spectranetics, and with the bubble effect, with some amount of contrast, we was able to cross the lesion, treat the distal lesion after this big curve, and then to advance a normal balloon, a small size balloon, to go down and treat the patient with PCI, as you can see, with a good results in implantation of 2 long stents from Cross. Same in right coronary artery, same as you can see, there is a lot of tortuosity and calcium here as well. So we decided to treat with laser and mother and child technique, and then balloon and stent implantation with a very good result. Another point is that there are patients who are developing shock, and I think we need some tools in this field. I know that the trials are lacking because the results in the trial for shock setting is not giving very good results, but I think despite that, every cath lab should have different ventricular assistant device. Recently, the American Society divided the shock in different levels. I think it is very useful to understand which device for each level. I think if the A to B level, so at risk and beginning risk of shock in this patient, it's good for EABP. I think if you go higher, you need Impella or even more complex devices like the ECMO. This is the case for this kind of procedures. It's a young lady with a ST elevation MI. There is some calcium and also thrombus in the mid-LAD. Was trying to go with a balloon, but it was impossible, so we started with rote ablation. But after the first pass, as you can see from IVOS, there is calcium 360 degrees at that point, but the patient arrested suddenly, so we had to perform the compressions, and there was no possibility to come out for this situation. So we implanted the Lucas just to take time and call the ECMO team. And this patient, after the ECMO implantation, was really stable. It was very easy to implant the stent and to have very good results and very good long-term result in the left ventricle with this kind of procedure. Obviously, it's not the normal case, but if you don't have ECMO in this patient, you should probably just see him die without any attempt to do anything else. And another thing I want to highlight, if you need CTO tools, and at least one operator with CTO skills, because I think there are patients who deserve more than the normal PCI. I show you a clinical case. It's a very young female patient, not previous events, with a good ejection fraction 2004, and admitted for heart failure. As you can see from the images, you can see the ejection fraction lower down to 30%, and there was also a moderate to severe mitral regurgitation. So we discussed this patient after the coronary angiography. As you can see from the coronary angiography, there was a 3-vessel disease, a total occlusion of the right, a total occlusion of the circumflex, a total occlusion of the LAD. We discussed this patient with the surgeon, but the surgeon offered cabbage plus mitral, mechanical mitral valve, but the patient refused this kind of treatment for some reason regarding her experience in the past. And so we decided to offer another option to the patient. We tried to do PCI in this patient, and we were able to recanalize the right coronary artery by antegrade approach with an antegrade wide escalation, implanting one long stent. As you can see, the right coronary artery is not very big. It was not very clear from the beginning. And then we shift to circumflex. It was very easy to go sliding up to the distal circumflex. That's probably much more important than the RCA. We implanted the 2 stents here also. And then we opened the LAD, luckily just by antegrade approach with another antegrade Y escalation. We were able to implant 2 long stents in LAD also. And the incredible thing in this patient is that despite the very good results angiographically, as you can see, LAD is patent now. In this patient, after 6 months, the ejection fraction completely changed up to 50%, and the mitral regurgitation was reduced just to mild. So I want to conclude my presentation saying that we should pursue the best strategy for patient prognosis. We should give always optimal medical therapy. This is not an option. We should add PCI to the optimal medical therapy in any case. We should just try to assess the patient preference, because we have situations where we have multiple therapeutic options, like optical medical therapy or PCI or cabbage, and so we have to be very clear with the patient. And another thing is that we should obtain the best complete revascularization. Obviously, sometimes it's impossible, but we should try to keep the best, even with PCI or cabbage. So if we fail with PCI, we should extend the patient to cabbage. In PCI, we should always treat ischemia and not lesions, and so if there is any doubt, you should assess with FFR. And in the modern cath lab requires wide options of tools, so many guide wires, balloons, the best technology for your stent, and always technology for example of calcium treatment. Modern cath lab, I think, requires at least one skilled CTO operator. You don't have to gain these skills in just 1 month. You can have a proctoring program, like to have another center helping you in that, but I think in the 2 to 5 years you should have this operator ready in your cath lab. Thank you very much for your attention.
Well, thank you, Dr. Carlos, for summarizing the current information on treatment of both stable as well as acute coronary syndrome patients. Well, as far as the schema trial is concerned, the results are interpreted differently by different people. So, as you agree that PCI definitely leads to lesser angina in patients who have got frequent angina. One thing which was not proven was that it was beneficial in MI patients or reducing MI. Well, let me put forth my views. If you see that in early phases, there was more periprocessal MI in the invasive arm. And that was primarily because of biochemical MI, because we were depending on the biochemical markers and not the actual clinical events. But later on, the spontaneous MI were reduced in the PCI arm, and those were really clinically significant. So, as a interventionist, I would say definitely that MI has, I mean, patients have lesser MI if you proceed with PCI. Well, that's open to debate, but that is how I interpret the schema results. So, the results are not against the use of PCI in stable patients as far as reduction in MI is concerned. So, what are your views?
I completely agree with you. I think the main point that I focused on this trial is that you can give an option to the patient probably you wouldn't give just a couple of years ago. So if a patient has significant ischemia, two vessel disease, I think it is fair to offer PCI or optimal medical therapy because the mortality is very low. So it is always an option. But as you could imagine, I'm performing PCI, so I strongly believe that reduction in ischemia has a role and that you can focus on the long-term results. So it's just a 5 years follow-up study. I'm pretty sure that if you would have 10 years, you would see some benefits much more evident than this. And obviously, if you have a young patient, you cannot think about just your 5 years later. You should think about 10, 20, or 30 years later. So this is why if it's a young patient, I try to give them the best and explain him why and which is are the options. But obviously, if you have an 85 years old man, I think you should focus on the more basic outcomes.
Thanks. Dr. Nagendra, please.
Dr. Brajesh, can I have one comment and then we can go ahead with my
Yes.
presentation?
Yeah. So, first of all, I congratulate you for that last case. I mean, 3 CTOs and moderate to severe MR. Actually, I don't know how many of us given option of angioplasty. I just straightway say you need a CABG with MBR. That's all. 3 CTOs. I mean, okay, you can get away 1, 2, 3. Expert work, excellent work. I must congratulate. Good for interventional cardiologist. Second thing, if you compare with two lesions, I mean a lesion which is 80% stenosis, a lesion which is stented now. Which one has got more chances of becoming a critical one? That is how I see my patient. Suppose I do an angiogram and I find a lesion which is 80%, and if I leave it on a medical management, and otherwise I do an angioplasty and put a stent, out of these two scenarios, which one is going to create more issues in future? I strongly feel that the one which I have left 80% because of some associated turbulence across the lesion, that lesion has got more chances of developing an MI. And I have seen this is happening. Suppose you have a patient who has come with a double vessel disease and you stent one and you leave the other one on medical management. Very often, very soon, you see a patient coming with the other lesion getting stenosis with unstable angina or annuation. This is what my experience is of. So I don't know. This is how I feel as an interventional cardiologist. I'm aggressive in doing angioplasties. If there is a documented ischemia, there has to be a documented ischemia. So documented ischemia means if the vessel is straightforward, it's not a side branch. I think it needs an angioplasty.
I agree with you, Dr. Kanvar, but I think my case was provocative, obviously, because this is a clear cabbage and valve patient. But I want to highlight that sometimes the patient decide they don't want to have cabbage, and I think you should give option to them. You should not force them to go PCI. Obviously, it's a cabbage patient. But if they refuse, I think it is fair to try to do something. I was very clear with the patient. We can try with PCI. If something's going wrong, we can risk the procedure, but we can stop and try to reconsider it cabbage. And sometimes the patient changes idea. but obviously you have to do it with,
excellent result.
yeah, you have results like this. Obviously, you think about PCI as a real option, but you cannot just talk about this comparing with what's going on in this patient, because obviously this is an exception.
Okay,
Regarding the PCI,
what is your incidence of how many times do you use intra-aortic balloon pump now? Are you using an intra-aortic balloon pump?
I know that in US, Impella just decreased the number of intra-aortic balloon pump, but I think there is a big role in the intra-aortic balloon pump right now. There are many patients who really benefit from this device. I know that the evidence are very low, but I'm still using a lot in a lot of patients. Obviously, I try not to use if the patient is like stable, but for example, there are some exceptions to this rule. For example, in complex procedures with